Well, nice to see all of you again. I've been so impressed with the quality of these lectures. I hope you've enjoyed them as much as I have. I think they've been spectacular. William Osler said medicine is a science of uncertainty and an art of probability. We're going to talk a little bit about decision instruments, decision making, and then how we might utilize them to curtail unnecessary imaging and why that's important in children. So decision making, the first understanding of probability theory came in the 17th century. You may have heard of the name Pascal. Modern decision therapy developed in the first third of the 20th century by Frank Ramsey, who was a mathematics professor at Cambridge. There were 8 axioms, and the key here is that using this decision therapy is to ensure that outcomes would be compatible with maximizing expected value. Then formal decision making evolved into 4 core elements, probably the most important of which is the decision maker or the deciders. And that's what we all confront every day, and that we're asked to choose from a set of alternatives. But also what's important in that is when choosing this outcome, we also must consider the state of all other alternatives. So there are models of decision making, and I think in modern medicine, and every one of you here use both models. So there's analytical, that's hypothetical, it's deductive. You can almost think of Sherlock Holmes. And then there's this intuitive or heuristic model of decision making in which it really evolves on pattern recognition. And I know for myself, I can look at someone and have a good idea of whether they're really hurt or not hurt, or they're really sick or they're not sick. So there are a number of things that contribute to poor decision making. It can occur from without sufficient information, made too quickly, made without proper reflection, made on a personal belief or bias rather than evidence-based. Faults in medical decision making are characterized by a narrowed framing, a confirmation bias. We're biased by our previous experience. Emotional bias in that, once we work on a diagnosis, the more we invest in a diagnosis, the less likely we are to abandon or consider alternatives. And then, of course, overconfidence. And that's what I'm often accused of as a surgeon. My daughters always say, never right, but never in doubt. But anyway, this is when we believe we are correct more often than we actually are. So there are external factors. We work in a very complex environment, and we have evolved towards shared decision-making, not only with our colleagues, all the team members, but also the patient. There are time constraints on our decision-making, particularly when someone is seriously hurt. We're tired, we work long hours, we may have unconscious bias, and of course there's this knowledge gap. So the study that was recently published that hit the headlines was basically that, believe it or not, medical errors are now the 3rd leading cause of death in the United States. That's scary. So we do have to make decisions better. The challenge is that the medical information is proliferating at a pace that we can hardly keep up. The half-life of new medical information is 5 years. So what I read today may not be relevant 5 years from now. I think this cartoon nicely shows that. It's expected by the year 2020 that there will be a 200-fold increase in the amount of medical data and facts, and that this is impossible for a human to process. It's going to get worse. The medical data not only is expiring at a 5-year pace, but it doubles every 5 years. So not only is much of what we're learning going to not be relevant, but that it's also we're getting that much more information. And sadly, and it's great that you all have committed this time to the meeting, that 80% of physicians can't spare more than 5 hours a month to try to keep up. So now I'm going to turn to a little background about radiation risk. In 1979, Cormack and Hounsfield won the Nobel Prize for Physics in their development of the CT scanner. So now if we look at this graph, in 1979, they received the Nobel Prize. And then you can see just the logarithmic growth in the use of CT scan in the United States. So that by within 15 years, we'd gone from essentially no CT scans to over 60 million scans performed annually. It's important to remember that ionizing radiation from a CT scan varies anywhere from 100 times to 1,000 times the dose delivered by a plain X-ray. So again, taking us back to 1979, the physics prize, Nobel Prize for Physics, about 15% of the ionizing radiation exposure to the American population was 15%. By 2006, over half of the ionizing radiation exposure we receive is from medical imaging, leading to a doubling of the effective dose per individual in the United States. This caused great alarm, and so many medical journals, particularly those relevant to children, began to really ponder and question this liberal use of CT imaging for children due to the radiation risk. So again, public became outraged. There were headlines that really were across all forms of media, really raising concern in the public's eye about what were we doing to children with these CT scans. Of course, we look at that with some hesitation. Can it really be accurate? But this is really something that is very striking from this article in USA Today. An ordinary CT scan delivers roughly the same amount of radiation, 3,000 millirams, as Japanese survivors of the atomic bomb received a mile or two from ground zero. Holy cow. I go into the scanner and it's like being a mile or two from a mushroom cloud. Wow. So what is exactly the risk? Well, the far left is Chernobyl. Some of you are probably too young to remember Chernobyl, but it was a nuclear reactor in the Ukraine that had a meltdown. It created a dead zone due to the radiation poisoning of the soil and the structures around it. And shortly after Chernobyl, we began to see almost an epidemic increase in thyroid cancer. And here's a father and a child, both with bandages over their thyroidectomies. Well, there's two types of radiation exposure, and this is a linear one in which it produces acute somatic effects, and it's really dose dependent. If you're at less than 250, you have no detectable effects. 1,000 to 3,000, you have nausea, vomiting, and infection due to suppression of your immune system and the damage to cells that are turning over very rapidly, particularly your GI tract. 3,000 to 6,000, the symptoms are more severe. You now become thrombocytopenic, and so you're suffering hemorrhage, and it can lead to sterility. And if you're exposed to more than 6,000, you die within 30 days. And a good example of this is Alexander Litvinenko. He was a CIA or a former KGB agent that was living in London. He was very opposed to the government in Russia at the time. He went to dinner with what he thought were two old acquaintances who were with the intent to poison him. They gave him 20 micrograms of polonium-210. He became sick and no one could figure out what was wrong with him. And then he began to manifest all the signs of radiation poisoning, and he died in 21 days after ingestion. So the biological effects of radiation damage rapidly dividing cells and those remain the most vulnerable. It also causes damage to DNA, leading to genomic instability. It can lead to reduced suppressor genes. Our DNA can repair itself, but it can interfere with that repair mechanism, and so as a result, the concern for cancer. So on the left is the mushroom crowd. If you're too close to this, you're going to have a linear exposure to radiation, and I think of this as like cooking a steak on a grill. If, on the other hand, radiation from imaging is thought to be in this linear quadratic, and such that these doses of radiation become cumulative over time, and with sufficient exposure, you begin to reach the same risk as you would if you were exposed to linear dosing. A little bit like my microwave. If I put something in there and don't heat it long enough, it doesn't taste very warm. But if I keep putting it in there, it's going to look like that steak. So in 1945, we dropped the atomic bomb on Hiroshima and Nagasaki. This lifespan study of atomic bomb survivors was conducted, and it had 50 years to examine these people who survived the atomic blast. And they found, no surprise, that there was an increased risk of solid cancers. And children demonstrated the highest cancer mortality rates. So here's that graph, and it's showing on the bottom the amount of radiation that they received in REMS. And then on the vertical axis, you see the increased risk of cancer mortality. I've superimposed the dose range of what a pediatric CT scan might deliver. And you can see that depending on the type of CT, not just, and this is just one CT, if you can imagine if there are multiple, that you're now in this dosing range in which that we can anticipate a higher cancer risk. Well, Alice Stewart was really a pioneer. She was an epidemiologist and a pediatrician, and she warned that there was no safe dose of radiation. It wasn't uncommon in the 50s for women to get X-rays while they were pregnant to see the lie of the baby, to anticipate a difficult delivery. And she reports the risk to fetus was significant. And again, as I said, she argued no radiation is safe. And here in her epidemiologic paper, on all these different types of pediatric cancers, the relative risk for mothers exposed, those fetuses, was significantly increased. So Brenner began to really bring this to attention and said that the estimated lifetime cancer mortality risk attributable to radiation exposure from one CT scan in a 1-year-old is 0.18%. For the abdomen and 0.07% for head, an order of magnitude greater than for adults. And here are the graphs. And while children only represent 4% of all CT imaging, they will account for 20% of the total potential cancer mortality from CT. And here you can see the age of exposure. No one is immune. Even at my age, there is some risk due to a CT scan. And you can see the increased risks in the head and the abdomen. So as he notes, the largest increases in CT have been in the categories of pediatric diagnosis or in adult screening, i.e. the trauma pan scan. The evidence is reasonably convincing for adults and very convincing for children. And so if you still are a doubter, there have been 2 studies, this one from England, and this looked at children who had cancer and underwent imaging. And when children have cancer, they get a lot of CT imaging. And what they found, even in just 10 years after, that they're starting to see a signal, depending on the dose, of increased cancer risk of bone marrow and brain. So let's turn now to the purpose of this talk. So we are taught about A, B, C, D, and E. I have to remind the residents that C does not equal CT scan. This is what it looks like in terms of how Similarly, we've increased CT in the diagnosis and evaluation of injured children. There's been nearly a 400% increase in the use of CT chest and of cervical spine, and there have been increases in other abdomen and miscellaneous. In a paper we wrote, I talked about this yesterday. This is Dr. Trunke's original triad of death in terms of when do patients die following injury. We talked about those that suffer immediate death, that's 50%, those that die early, which we've heard about from me and Dr. Schreiber and others, from exsanguination, airway obstruction, neurologic injury, and those who die a delayed death from the complications of their injuries. But as Hunter pointed out, perhaps there will be, in the years to come, a fourth peak of traumatic death, and that'll be those observed years from now due to ionizing radiation. So, again, we activate our trauma team, and here's our patient. Uh-oh, I think I poopies, because I'm going to get scanned from head to toe. This was a study where we looked at patients, children, who were being evaluated from trauma. We divided them into 4 groups. Mechanism alone, those patients who had abnormal GCS, abnormal vital signs or physical exam, or both. You can see that there was a high use of CT in their evaluation. They often they all had more than almost 2 scans. And we didn't do too bad if you use scanning for some findings that suggest there's an injury present, ranging anywhere from 22 to 25%. But this was what was most striking. When we imaged simply on the basis of mechanism, no serious injury was identified. We can do better. So when you look at the dosing that they received, the hashed line represents the annual maximum safe dose of radiation as determined by the government. And you can see in both categories, we have exceeded that annual maximum safe dose. So this study was examining based on current amount of CTs that we do annually, the number of future pediatric cancer risks per year, or cancers that will be observed per year. So if we do nothing, that's the red bar, those are the number of deaths, but we can see that if we reduce the number of CTs and reduce the dose, we will impact these future pediatric cancers. So decision instruments apply evidence-based medicine to help us to make informed and objective clinical decisions. Essentially, they help us to determine the best course of action. Decision instruments provide an opportunity to reduce radiation exposure as well as cost. So here you can see in the top part of this graph is that if we're evaluating chest trauma and we just get a chest x-ray, we'll find about 3 with major clinical significance. If we get a chest CT, it doubles, but if we do both, we actually do worse. And similarly, if we do both, costs are exponentially increased. Decision instruments can also be used for quality improvement. We were very concerned about the rise of CT chest, particularly since children rarely, almost reportedly, suffer great vessel injury, and in many ways that's the only indication for a chest CT, and I'll show you why in a minute. So this is SPC charting. It's a tool used by manufacturing. So you'll look at your data from maybe quarter to quarter or month to month, but you really can't say with accuracy whether you're making improvement or not. So before we implemented our decision guideline, 11% of children were getting CT scans of the chest. We did provider education, but you can see that the trend line did not change. And then we implemented our imaging guideline with some education. We now dropped to 7%, and with continued effort, we're now down at this point in time to about 1%. So there have been a number of decision instruments specifically looking at ways to reduce the CT dose, reduce the number of CTs ordered, and utilizing decision trees. The first is Nexus criteria for chest, and why I said this was important is we looked at all these chest CTs we were getting, and there's no question you will find more injuries by CT, but there are not injuries that require intervention. We know that we watch, Dr. Natrika has published that we can watch occult pneumothoraces in children. We know that pulmonary contusions require supportive care. And so most of these things that we're seeing do not require intervention and therefore would argue, why are we getting chest CT? The Nexus decision instrument was developed primarily for adults to reduce chest imaging in adults. And here were a whole category of injuries which had major significance, minor clinical significance, or no clinical significance. And from that, they derived a decision instrument which really, if they met criteria, should get a CT. The trouble is, when we think about specificity, the specificity using this instrument is very low. So even though we'll reduce some, still 13% of these patients will be imaged appropriately, but leaving 87% that really didn't need the chest CT. So again, ongoing work to help us refine these criteria. The PCARN study for imaging brain injury, again, if a patient has a low GCS or other signs of altered mental status or signs of basal skull fracture, well, they have a 4% risk of a clinically important TBI, and therefore CT is recommended. The next category says, well, maybe there's a 0.9%, but maybe observation is an appropriate alternative. But here's the key point. When you get to these bottom of these decision instruments, and if they don't have any criteria, don't CT them. The same is true for the study on Cspine Clearance. This study was published in Pediatrics in 2001 and has been one of the more durable decisions instruments. It had 100% sensitivity. It had a negative predictive value of 100%. In all patients who had injury, reported pain, or had neurologic findings, or had altered mental status. And if you use this, it would reduce 20% of unnecessary imaging. The Canadian rules have improved upon this. So again, look at the Nexus study, 12%. That means if you met criteria, still 88% of patients didn't need the CT. The Canadian rules have made that better so that now it's 50-50. For the general surgeons, this is the one I like. This is the one we use. This is a PCARN study looking at blunt trauma. The thing that's unique about this, it was a prediction rule consisting of 7 patient and physical findings without laboratory or imaging information. It performed very well, again, though the specificity is low, so still using these rules, half the patients might get imaged unnecessarily. So here it is briefly, and so if they have low GCS or a seatbelt sign, well, physician judgment is necessary because not all marks on the abdomen are the same. And then these others, perhaps, but again, if they have none of these findings, they have a 1 in 1,000 risk of needing an intra-abdominal intervention. That's what IAI stands for. Well, this nice commentary when this paper came out by Dr. Green really points out how we have to look at these instruments. Does the rule address a clinically relevant question? Has the rule been externally validated? Is the rule one way or two ways? And this is a little complex to understand, but if a rule is one way, then it means that you have to use clinical judgment in conjunction with that. And we'll use that home study in a moment to go over that. A two-way rule says you image if the criteria are met, but not if they're absent. And then we want rules that will exist on, will improve pre-existing clinical practice. So going back to the Holmes rule, if we use it the way it was intended, for 45% of the patients will get a CT. If we use it in a one-way fashion, where we also use clinical judgment, we'll reduce imaging by 11%. But if we use it in a two-way fashion where we say we're going to image all of these patients for every one of these criteria, we don't decrease imaging, we actually increase it by 13%. So how might I construct a decision instrument? Well, a lot of that stuff's too sophisticated for me. So I picked this guy with one arm feeding a crocodile. Feeding a crocodile? Stop. Risk of limb loss, 0.1%. Feeding the crocodile again? Stop. Risk of limb loss, 1 in 10,000. I still don't think, despite what the instrument says, you should feed a crocodile a second time if you've lost your arm the first time. So now I get to put the hair shirt on. Neither decision instruments or clinical judgment is perfect. I was on call. I was telling the resident about the home study. I had a 7-year-old restrained passenger in a motor vehicle crash. GCS is 15. Oh, okay, home study said under 14. Hemodynamically stable, no mark on his abdomen, no peritoneal findings of negative FAST. And I said, oh, let's just admit him and watch him. And why? Well, the probability of needing an intervention was 1 in 1,000. Well, 6 hours later, the resident calls me. The child has an increased heart rate, he's febrile, and he's complaining of abdominal pain. I said, well, we better get a CT scan. The CT scan showed free fluid and bowel thickening. We took him to the OR. He had an isolated perforation of his jejunum. He was fortunately discharged home in 4 days after an uncomplicated stay. So it's apropos that we're in a casino because I didn't hit the all-win bars. So you have to put these risks in perspective. The lifetime risk of cancer is 44% for men and 38% for women. A single CT scan for a child age 5 theoretically increases that risk by 0.2%. Physicians need to understand risk-benefit. The risk of a missed diagnosis is immediate and real. The risk of radiation exposure is delayed and, yes, still somewhat theoretical. If an institution performs 300 CT scans per year, the risk-benefit equation balances if one CT saves one life every 4 years. Well, I'm going to close with the future is coming. When I was thinking about that I had given the committee this talk, I thought, well, this is like me in talking about transportation in the horse and buggy era. I'm going to tell these people about this thing called an automobile that'll take you 40 miles in about 30 minutes or an hour. Or this thing that's called an airplane that's going to be able to fly you from city to city. So the real question is, will the art of medical decision-making persist in the era of big data, machine learning, and artificial intelligence? How technology may impact decision-making? Well, there's big data out there. Every one of us is being tracked, and data is constantly being mined about us. And they have the ability to sort it and search it. And so there's a thing called Google Trends. And when the flu outbreak came, Google Trends showed that predicted flu before the CDC did. There's machine learning. There's artificial intelligence, and then you combine artificial intelligence with big data. So this is how we currently approach problems. This is the way Watson approached a problem. And as an example, a patient in Tokyo had leukemia diagnosis and no treatment was worked. They loaded Watson with 20 million cancer research papers. Watson came up with the proper diagnosis in 10 minutes, suggesting a new treatment that has now become the standard. This is the current state, and if this is what ideally, it will not replace us, but that we will be able to participate. Thank you.